Chronic hypertension is defined as documented blood pressure more than 140 over 90 millimeters mercury occurring before or during the 20th week gestation. There is difficulty with the diagnosis and management due to the physiologic drop of blood pressure during the second and early third trimester in both hypertensive and normotensive women. This also leads to the difficulty in determining whether the hypertension is chronic or pregnancy induced, especially during the third trimester, wherein the blood pressure returns to the original hypertensive levels. Superimposed preeclampsia is diagnosed if there is new onset or worsening baseline hypertension accompanied by either of the following: proteinuria, thrombocytopenia, renal insufficiency, liver involvement, cerebral symptoms, and or pulmonary edema. Superimposed preeclampsia usually develops earlier in pregnancy. Blood pressure usually reaches the abnormal levels at around 24 weeks gestation and is associated with severe symptoms as well as fetal growth restriction. Preeclampsia is common to young and nulliparous women, while older women are prone to develop chronic hypertension with superimposed preeclampsia. Women who are more likely to develop gestational hypertensive disorder are the following. Next slide, please. So these are the important mechanisms causing preeclampsia: placental implantation with abnormal trophoblastic invasion of uterine vessels, immunological maladaptive tolerance between maternal, paternal, and fetal tissues, maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy, genetic factors including inherited predisposing genes and epigenetic influences. Pregnancy complicated by chronic hypertension are at increased risk for a variety of maternal complications, including superimposed preeclampsia, pulmonary edema, placental abruptio, acute renal failure, cerebrovascular accidents, stroke, and maternal death. The rate of many complications associated with superimposed preeclampsia appear to be similar to the phase noted with severe preeclampsia. Sudden and severe increases in blood pressure may be the presenting feature of hypertensive disease in pregnancy, intrapartum, or in the postnatal period. Blood pressure greater than or equal to 170 millimeters mercury systolic or 110 millimeters mercury diastolic constitutes severe hypertension requiring urgent treatment. While there is no controlled trial to determine how long severe hypertension may be left untreated, it is recommended that treatment be administered promptly, aiming for gradual and sustained lowering of blood pressure. So, a variety of medication have been used for the treatment of severe hypertension in pregnancy, which includes labetalol, nifedipine, hydralazine, and diazoxide. However, labetalol is not available in the Philippine market. So there is concern that a precipitous fall in blood pressure after antihypertensive treatment, particularly intravenous hydralazine, may impair placental perfusion, resulting in fetal distress. This can be prevented by co-administration of a small bolus of fluid at the time of administration of antihypertensive therapy. Continuous CTG monitoring could be considered in these situations, particularly when there is evidence of existing fetal compromise. However, fetal distress as a result of such treatment is rare. So the concurrent administration of longer-acting oral agents such as methyldopa, clonidine, labetalol, oxprenolol, nifedipine, prazosin, and hydralazine will achieve a more sustained blood pressure lowering effect. So objectives in the management for pregnancies complicated by preeclampsia are as follows: termination of pregnancy with least possible trauma to both mother and fetus, birth of a healthy newborn that subsequently thrives, complete restoration of the health of the mother. In most of the cases, the above mentioned are met through induction of labor. The goal in the evaluation of preeclampsia is early diagnosis to prevent worsening of the condition and management plan for timely delivery of pregnancy. Although the mainstay of treatment for preeclampsia is termination of pregnancy, most of the cases of preeclampsia are managed conservatively due to mild symptoms. Ominous signs of preeclampsia include oliguria, headache, visual disturbance, epigastric pain. The latter three are also indicative of imminent convulsion. In managing severe preeclampsia, anticonvulsants and antihypertensive are given followed by termination. In preterm gestations, the pregnancy is temporized to reduce the risk of neonatal morbidity or from serious morbidity related to prematurity, granting that the degree of preeclampsia is mild. So, according to ACOG 2016, assessment of placental functioning and fetal well being, such as non stress testing and biophysical score, are one. So during the 1990s, the prevailing practice was that women with severe preeclampsia were delivered without delay. Nowadays, conservative or expectant management is being practiced by some clinicians, aiming to improve fetal outcome without compromising maternal health. As such, these patients require inpatient maternal and fetal monitoring. Sebas and Memphis in 1985 attempted to prolong pregnancy in women with severe preeclampsia between 18 and 27 weeks. There was a high perinatal mortality rate. There were no maternal deaths, however. Complications include abruptio placenta, eclampsia, renal failure, hypertensive encephalopathy, intracerebral hemorrhage, and ruptured hepatic hematoma. So the criteria were later on redefined as aggressive versus expectant management at 28 to 32 weeks. Aggressive management includes steroid administration for fetal lung maturity, followed by termination of pregnancy after completion of steroids. In expectant management, antihypertensives were given for severe hypertension. The pregnancy was prolonged in the expectant group with overall improvement of neonatal outcome. However, in a follow-up observational study, Memphis compared three groups: women with complete HELP syndrome, partial HELP syndrome, and severe preeclampsia without HELP syndrome. In this study, it was conducted that severe preeclampsia and HELP syndrome can be managed expectantly. However, those with intrauterine fetal growth restriction have shorter interval to delivery duration. Later studies done by Siba and Barton showed that expectant management with severe preeclampsia at 24 to 32 weeks were related to serious maternal complications, which are placental abruptio, HELP syndrome, pulmonary edema, renal failure, and eclampsia. Fetal growth restriction was also common in this group. Severe preeclampsia in less than 23 weeks gestation, it is recommended to terminate the pregnancy since fetal survival during this time is impossible. Pregnancies at 24 to 23 weeks have 60% chance of survival and a 90% chance of survival in gestation reaching to at least 26 weeks. So for the postpartum management, during the first 6 weeks, many women with pre-existing hypertension with or without superimposed preeclampsia, blood pressure is often unstable immediately after delivery and may require medication adjustment. For women with chronic hypertension, a long duration of antihypertensive treatment in pregnancy, higher maximum systolic and diastolic blood pressure, higher body mass index, or occurrence of preterm preeclampsia are more likely to have sustained hypertension postpartum, which exceeds 6 weeks. So, blood pressure usually stabilizes in the first 2 months following pregnancy, and treatment and appraisal should be based on the assumption that levels will decline. Severe postpartum hypertension requires the same management approach as during pregnancy. Postpartum women with comorbidities should be treated according to standard guidelines for their specific medical condition when not pregnant. This could be longer term target and may not be achievable while the patient is hospitalized. Conversely, a reduction in medication may be required within 1 to 2 weeks of delivery if the woman's antihypertensive therapy was augmented in relation to the pregnancy. So, women with pre existing hypertension who did not require treatment during the pregnancy often need treatment postpartum. Those at highest risk appear to be preterm deliveries and multiparous women with elevated serum urate concentrations. Follow up after 6 weeks is required to ensure resolution of pregnancy related changes and ascertain the need for ongoing care particularly further investigation and management of the renal disease. In women whose blood pressure control before pregnancy remains uncertain, it is important to ensure normalization of blood pressure as well as albuminuria postpartum. Women with persistent hypertension not previously assessed should undergo routine workup according to standard regimens. Advice regarding future lifestyle and optimization of risk factors in subsequent pregnancies may be required. This is particularly relevant for women who are obese, have cardiovascular risk factors, secondary hypertension, or end organ disease. So let me discuss one of the complications of chronic hypertension with superimposed preeclampsia, which was also present in our index case. So cerebrovascular accident, otherwise called stroke, is the third major cause of morbidity and mortality in many developed countries. Stroke can either be ischemic or hemorrhagic. Ischemic stroke is due to the loss of blood supply to an area of the brain. It is, it is a common type of stroke, while hemorrhagic stroke is due to bleeding in the brain by the rupture of a blood vessel. Hemorrhagic stroke may be further subdivided into intracerebral hemorrhage and subarachnoid hemorrhage. Intracerebral hemorrhage is bleeding into the brain parenchyma, while the subarachnoid hemorrhage is bleeding into the subarachnoid space. So, hemorrhagic stroke is associated with severe morbidity and high mortality. Progression of hemorrhagic stroke is associated with worse outcomes. Early diagnosis and treatment are important in view of the usual rapid expansion of hemorrhage, causing sudden deterioration of consciousness and neurological dysfunction. Hypertension is the most common cause of hemorrhagic stroke. So, long-standing hypertension produces degeneration of the media, breakage of elastic lamina, and fragmentation of smooth muscles of the arteries. Lipohyalinosis, fibrinoid necrosis of the subendothelium, microaneurysms, and focal dilatations are seen in the arterioles. The microaneurysms are named as Charcot-Bouchard aneurysms. These aneurysms is defined as aneurysms of the brain vasculature, which occur in small blood vessels, which is less than 300 micrometer in diameter, most often located in the lenticulostriate vesicles of the basal ganglia and are associated to chronic hypertension. So the common sites of origin of hypertension-induced intracerebral hemorrhage are the small penetrating arteries that originate from basilar arteries or the anterior, middle, or posterior cerebral arteries. Small artery branches of 50 to 70 nanometers in diameter have multiple sites of rupture associated with layers of platelet and fibrin aggregates. Hypertensive change causes non-lobar intracranial hemorrhage. Acute hypertension, as seen in preeclampsia, also causes intracranial hemorrhage, known as postpartum intracranial hemorrhage. Cerebral amyloid angiopathy is an important cause of primary lobar intracerebral hemorrhage, which is seen in older adults. It is characterized by deposition of the amyloid beta peptide in the capillaries, arterioles, and small and medium arteries in the cerebral cortex, leptomeninges, and cerebellum. So other important risk factors are listed in this slide. Next slide. Next slide. So the usual cause of spontaneous subarachnoid hemorrhage are ruptured aneurysms of a cerebral artery, arteriovenous malformation, vasculitis, cerebral artery dissection, dural sinus thrombosis, and pituitary apoplexy. The risk factors are hypertension, oral contraceptive pills, substance abuse, and pregnancy. Intracranial hemorrhage of pregnancy occurs with eclampsia. It is due to the loss of cerebrovascular autoregulation. So the common sites of the bleed are the basal ganglia, which accounts to 50%, cerebral lobes, which accounts to 10 to 20%, the thalamus, which accounts to 15%, pons and brain stems, which accounts to 10 to 20%, while the cerebellum accounts to 10%. So the hematoma disrupts the neurons and glia. This results in oligemia, neurotransmitter release, mitochondrial dysfunction, and cellular swelling. Thrombin activates microglia, causes inflammation and edema. So the primary injury is due to the compression by the hematoma and an increase in the intracranial pressure. Secondary injury is contributed by inflammation, disruption of the blood-brain barrier, edema, overproduction of free radicals such as reactive oxygen species, glutamate-induced excitotoxicity, and release of hemoglobin and iron from the clot. So usually, the hematoma enlarges in 3 to 12 hours. The enlargement of hematoma occurs in 3 hours in one third of cases. The perihematomal edema increases in 24 hours, peaks around 5 to 6 days, which lasts also to 14 days. There is an area of hypoperfusion around the hematoma. So the factors causing deterioration in intracerebral hemorrhage are expansion of hematoma, intraventricular hemorrhage, perihematomal edema, and inflammation. Cerebral hematoma produces hydrocephalus by compression of the fourth ventricle in the early stage. The common presentations of strokes are headache, aphasia, hemiparesis, and facial palsy. The presentation of hemorrhagic stroke is usually acute and progressive. Acute onset headache, vomiting, stiffness, increases in blood pressure, and the rapidly developing neurological signs are the common clinical manifestations of hemorrhagic stroke. Symptoms can lead to extent and location of hemorrhage. So cerebral hemorrhage produces symptoms of raised intracranial pressure such as lethargy, vomiting, bradycardia. Progressive neurological deterioration indicates the enlargement of hematoma or an increase in edema. So CT scan is usually the initial investigation, while MRI can distinguish between the hemorrhagic transformation of infarct and primary hemorrhage. MRI can also detect underlying cause of secondary hemorrhages, such as vascular malformations, including cavernomas, tumors, and cerebral vein thrombosis, while CT angiogram indicates ongoing bleed and is associated with fatality. So blood investigations, such as getting your bleeding parameters, will detect any abnormality of bleeding or coagulation and any hematological disorder which can cause hemorrhage. Liver function test and renal function test are also needed to exclude any hepatic or renal dysfunction as a cause. The investigation to rule out vasculitis are the quantitative evaluation of immunoglobulins, thyroid antibodies, rheumatoid factor, anti-nuclear antibodies, anti-double-stranded DNA, histone antibodies, complement anti-Ra and anti-La antibodies, cytoplasmic staining and perinuclear staining, anti-neutrophil cytoplasmic antibodies, and anti-endothelial antibodies. So for the BP management, BP should be reduced gradually to at least 150 over 90 millimeters mercury using beta blockers, ACE inhibitors, calcium channel blockers, or hydralazine. Management of raised intracranial pressure includes elevating the head of the bed to 30 degrees and osmotic agents such as urmannitol, given at a dose of 1.0 to 1.5 grams per kilogram. Hyperventilation after intubation and sedation will also be will also be necessary if intracranial pressure increases further. And also hemostatic therapy is given to reduce the progression of hematoma. This is especially important to reverse coagulopathy in patients taking anticoagulants. Vitamin K prothrombin complex concentrates, recombinant activated factor 7, fresh frozen plasma are used in these cases. So ASA recommends that patients with thrombocytopenia should receive platelet concentrates. Patients with elevated prothrombin time INR should receive intravenous vitamin K and fresh frozen plasma and prothrombin complex concentrates. So around 3 to 17% of patients will have seizure in the first 2 weeks, and 30% of patients will show electrical seizure activity on EEG monitoring. Those with clinical seizures or electrographic seizures should be treated with anti-epileptic drugs. Lobar hematoma and the enlargement of hematoma produces seizures, which are associated with neurological worsening. Subclinical seizures and non-convulsive status epilepticus also can occur in these patients. Continuous EEG monitoring is indicated in patients with a decreased level of consciousness. Otherwise, prophylactic anticonvulsant medication is not recommended according to the ASA guidelines. So for the different types of surgical treatment for hemorrhagic strokes includes craniotomy, decompressive craniectomy, stereotactic aspiration, endoscopic aspiration, and catheter aspiration. So the secondary injury of hemorrhagic stroke comprises of inflammation, oxidative stress, and toxicity of erythrocyte lysase and thrombin. So strategies to reduce these are being tried. Pioglitazone, misoprostol, and celecoxib are now being used to reduce the inflammatory damage. Edavarone, flavonoid, and nicotinamide mononucleotide can reduce also the oxidative stress. Iron chelators, deferoxamine, is also used during the experimental phase. And also rosuvastatin, which is a competitive inhibitor of the enzyme 3-hydroxy 3-methylgluteryl coenzyme A reductase, was also associated with better outcome in a trial. The calcium channel blocker nimodipine improves outcome of subarachnoid hemorrhage by a neuroprotective effect. So, in conclusion, fetal mortality and morbidity is strongly associated with gestational age at delivery. Prolongation of pregnancy in the presence of preeclampsia carries no benefit for the mother but is desirable at early gestations to improve fetal prognosis. When the onset of preeclampsia occurs at a pre-viable gestation, which is less than 24 weeks gestation, there is little to be gained from prolonging the pregnancy with serious maternal morbidity and high perinatal mortality rates. So, in relation to our index case, prolongation of pregnancy could have resulted in a more serious maternal and perinatal mortality, as mentioned in our earlier slides. Conservative management would not be of benefit to both the mother and the fetus. The deteriorating maternal status would have caused the demise of our index case if the pregnancy was not terminated. In addition, it is not beneficial to the newborn since the prematurity would predispose to complications, which would make it harder for it to thrive and is related to long term complications. Delivery was beneficial to our index case and had greatly improved her prognosis and outcome.
um, of, of the history of this patient. So going back, she's 29. She's a gravida 2 para 0, 0100, 25 weeks preterm at 25 weeks and 2 days, age of gestation, she had chronic hypertension, and she has a CVD bleed. If you go back to the history, she had a prior pregnancy 4 years ago. It was again also for uncontrolled termination, was early, for an uncontrolled blood pressure. Of course, there was not much details, but the baby was preterm, and probably from the prematurity, the baby did not survive. So I would like to focus on what is the do our patients actually understand what their condition was in their previous pregnancy. So I came upon this article. It was about preeclampsia knowledge among postpartum women who were treated for preeclampsia and eclampsia. Okay, so they divided these women and then they asked them, okay, do they understand the diagnosis of their preeclampsia? Some said that yes, they fully understood, and also there was a group of these women, they only understood a little in terms of the diagnosis, but a whopping 38% of those women said they did not understand the diagnosis in terms of the cause why they develop hypertension in pregnancy. 71% of those women did not understand why were they developing the hypertension in pregnancy. In terms of complication, there was about almost half, okay, of women who were tested did not understand the complications. Even a whopping a very high, or even the future health effects of development of preeclampsia and eclampsia in pregnancy. So are we really educating these women properly? Okay, so for that they did counseling in different categories. So there were women, so were subdivided. They were grouped differently. There were women who did not receive any counseling, and then there were women who received counseling, more of the cause, their diagnosis. Well, there were another set of women were were counseled regarding the cause, regarding the diagnosis and the cause, and then another group of women were counseled for um, for the diagnosis, the cause, as well as the complications, and then lastly, there was a group of women who were counseled for all four concepts, for all four categories. That would be for their diagnosis, their causes, the complications, as well as the what is going to happen in their future pregnancies. As you can see, with the more counseling that was given to the patient, their knowledge on their preeclampsia and eclampsia syndrome also increased. So they concluded, okay, that counseling of by the healthcare providers were associated with a higher performance in terms of knowledge of assessment of preeclampsia and eclampsia in these patients. Thereby, with this one, there would be an improvement, okay, of their in their succeeding pregnancies in terms of promotion of early prenatal care, improve the self recognition warning signs, ultimately improving both morbidity and reducing mortality for these patients. Okay, what another point that I would like to discuss would be on when we operate on our preeclampsia eclampsia patients, we don't really go into this one. Their mental health issues that would be related. Okay, mental health is a very big issue nowadays. So how are they? Do we actually counsel them? Okay, so this is I came upon this paper. Okay, it is the effectiveness of psychoeducational counseling anxiety in our in preeclampsia patients. Okay. So it concluded they were subdivided into two groups. There was these women who were the control in the interventional group. Okay, in the interventional group they had two sessions with individual psychoeducational counseling, and they were made to their level of anxiety was measured using the state trait anxiety inventory pre-test and also a post-test. Okay. In conclusion, they noted that psychoeducational counseling significantly decreased the anxiety of level these pregnant women with preeclampsia. Okay. So that in order, it would really help them in their succeeding pregnancies. Okay. I think I wanted to talk about that because that first pregnancy, the one that was back in 2017, really put much anxiety and on our index patient that affected the her decision making in her succeeding pregnancies. What I would also like to emphasize is the need for preconceptional counseling. We just don't tell our patients, especially our preeclampsia patients, mom, this is what happened to you. Okay, so in your next pregnancy, it's gonna have you're gonna have another. Did you have a risk factor already? You're gonna have a higher chance of developing another hypertensive episode during your succeeding pregnancy. So you should what do we advise? We advise them that they should seek consult. They should have their prenatal checkups early, and they should be done in a hospital setting. Okay. So, but what we miss out when we advise these patients is the importance of preconceptional counseling. Okay, preconceptional counseling. We just don't. It doesn't really. It's not only involving mom. You just drink folic acid supplementation to prevent neural tube defects, but it's very important in our patients who are high risk, who have comorbidities, like our index case. Okay, she was hypertensive before. She most likely she definitely was a chronic hypertensive, but there was no really monitoring, no medications to put her on a good BP control. So management of not only other medical comorbidities like hypertension, but also the management of your diabetes and even your thyroid disorders are very important prior to even planning the pregnancy. So preconceptional counseling is very important. So for this index case, if she sought consult preconceptionally, in terms of we could have managed her hypertension very early on, okay, thereby preventing these complications that occurred during her second pregnancy, resulting in another premature baby that most likely did not make it. Okay, so for the management of hypertension in women who are planning pregnancy, okay, our we have these two medications. We already know them. What is available in the Philippines is if the patient has been on ACE inhibitors or angiotensin receptor blockers, then we could shift them to our what's available in the Philippines, which are methyldopa. Okay, especially in women with chronic hypertension, it would have been best if our patient had preconceptional counseling prior to getting pregnant, so we could have lessened the complications or the morbidity for her succeeding pregnancies. And of course, the ever present changes in lifestyle, as well diet and lifestyle. So we have to advise patients about balanced diet. It also has to include physical activity, and of course, no, they should discontinue smoking, no alcoholic beverages, no illicit drug use, and they should have regular and adequate sleep as part of our preconceptional counseling. So for this patient, she got pregnant after 4 years. True enough, she followed her obstetrician's advice. She sought prenatal consult very early on in the first trimester of pregnancy. However, during the course, she was around 2 months into her pregnancy. There was note already of BP elevation in the Dumanhong District Hospital. That's why she was referred to a higher center, which is Talisay District. There, she had a blood pressure of 200 over 120 millimeters mercury. She was advised admission, but refused. Okay, the if you could recall the history, the reason actually for her referral was that she was scared that they were already again going to terminate the pregnancy, okay, due to her uncontrolled hypertension. This brought about her going home against medical advice and leading to poor compliance. Poor compliance, no, meaning she didn't go into prenatal consults anymore. She didn't even take her antihypertensive meds. She was basically a ticking time bomb at this point. So at the first trimester of pregnancy, can we actually offer something for this patient? So the International Federation of Gynecology and Obstetrics, or FIGO, has this initiative of preeclampsia, okay, in terms of first trimester screening as well as prevention. So its objectives was to raise awareness to the links between preeclampsia and poor maternal and perinatal outcomes. They want to create a consensus document that provides guidance for the first trimester screening and prevention of preterm preeclampsia, and to disseminate this and encourage its use. So in terms of public health focus, it wants to again, increasing awareness and access, affordability, and acceptance of preconception counseling and prenatal and postnatal services for women of reproductive age. So for universal screening, FIGO recommended that all pregnant women should be screened for preterm preeclampsia during early pregnancy, specifically in the first trimester of pregnancy. It's a combination of tests of both maternal risk factors, biomarkers, and it's more or less a one-step procedure. And they even developed this risk calculator, which I will show you later on. Okay, it's available online. It's free of charge. Okay, so these calculators, a combination of the measurements of the mean arterial pressure, the serum placental growth factor, as well as the uterine artipulsatility index. So if not possible, especially the measurements of your placental growth factor or even the measurement of the uterine artery pulsatility index, a baseline screening test can be used by using maternal risk factors as well as with the use of the mean arterial pressure. So I will show you first. I'll show you this one. Okay, so this is the example of the calculators. As you can see here, that it would ask on the pregnancy type, if there's singleton and twins, pregnancy dating, which is very important. It's supposed to be early first trimester. We should already date our patients in terms of their age of gestation and obtaining the fetal crown rump length. And then maternal characteristics would be the date of birth of the mother, height, weight, the racial origin, the smoking in pregnancy, even the mother of the patient, does she have a history of preeclampsia, and any conception methods. Usually it involves, if it's spontaneous, it's a stimulated cycle or an IVF cycle. In terms of medical history, of course, our comorbidities are here: hypertension, diabetes, lupus, as well as your antiphospholipid antibody syndrome, and the obstetrical history. And then this one is the biophysical measurements would be already your maternal mean arterial pressure. Okay, and then of course the mean uterine artery pressure. This would be already done by our sonologists. Okay, and time of the date of measurement, and the presence and the biochemical measurements in terms of your growth factors, as well as your placental protein A growth. So I tried this. I more or less input the what you call this, the data of our patient, and some others I just have to made do, and then and this would come out. It would come out a recommendation. So for that particular patient, the recommendation by doing the calculator, the risk for preeclampsia was assessed by a combination of one's maternal and medical history, and the measurements of blood pressure as well as blood flow to the uterus. And it would give you a it would give an assessment that the patient is classified being increased risk for the development of preeclampsia even before 37 weeks. And it is recommended that a low dose aspirin, okay, should be started um, from at the time of this test until 30 weeks age of gestation. Okay. So the incidence of preeclampsia before 32 weeks was about 90%. This is very high. And even before 37 weeks, still at 60%. So going back to the last recommendation of FIGO, okay, in terms of prophylactic aspirin use, it is usually, they recommended it should be started between the 11 to 14 week age of gestation. And the dose is about 150 milligrams taken at night. It should be taken until the 36 weeks age of gestation, or when delivery will occur, or when your preeclampsia is already diagnosed. Low dose aspirin should not be prescribed to all pregnant women. That's why it's best to use the calculator, so that it would help, it would guide us on who are these patients that we would give to, who would be started on our aspirin. And also, FIGO also recommended the use of calcium supplementation. So it is not enough that we give our patients the 500 milligrams daily elemental calcium intake, but calcium supplementation should be increased to 1.5 to 2 grams to help reduce the burden of early as well as late onset preeclampsia. Okay, I think that that ends my reaction.
Dr. Abejero, a neurologist in Soto, as well in other hospitals. So, thank you, Dr. Owado, for the extensive discussion. No? And pretty much the patient's pretty lucky actually to survive given the stroke that she had. No, so basically, what do we know about hemorrhagic stroke in pregnancy? No, so actually in literatures, it's relatively rare, but it has significant mortality and morbidity. So if you also compare, the usual strokes or type of stroke the patient has during the pregnancy, it's usually actually hemorrhagic stroke that is more common, and this is due to the changes in the there are maternal physiologic changes that occurs that somehow affects, the pathophysiology of stroke. Okay, and also the same time, there is a threefold increase actually among pregnant women compared to non-pregnant. And it seems to be consistent also with our patients' profile, or demographic profile. The mean age actually where hemorrhagic stroke occurs in pregnancy is around 22 to 33 years old. So the highest risk by which stroke occurs is actually during the peripartum and postpartum phase, and mostly it's due to the hypertensive disorders of pregnancy. So as one of the most important contributors, and this will actually this hypertensive disorders that occur in pregnancy may actually result to premature later on to premature cardiovascular diseases, such as hypertension again, or essential hypertension for patients. But take note that aside from hemorrhagic stroke, there are other strokes that may occur in pregnancy. So the second most common among pregnancy is your ischemic stroke, followed by your posterior reversible encephalopathy. So it will present as seizures, decrease in sensorium, no, due to elevated blood pressure. You can also what you have what we call reversible cerebral vasoconstriction. It may present as severe headache, just thunderclap headache, just like an aneurysm, subarachnoid hemorrhage, no, or and at the same time, this is due to elevated blood pressure, and it's related to abnormal uh, cytokines that causes the vasoconstriction. And last of all is your cerebral venous sinus thrombosis due to hypercoagulable state that is usually also that one of the risk factors is actually pregnancy. So what are the causes of hemorrhagic stroke? In pregnancy, the most common still is your preeclampsia eclampsia, as in this case, no? So it's quite at the same time, given that the risk factor of the patient having a long chronic hypertension on top of the preeclampsia would actually result to a hemorrhagic stroke. Okay. So, but there are other etiologies or causes that may result to hemorrhagic stroke among pregnant women. Another consideration that you might want to look at are your AV malformation. So those are your abnormal tangled blood vessels, no, in your brain, or aneurysm. So if you have an aneurysm and it will rupture, that will result to a hemorrhagic stroke. So what are the proposed mechanisms for stroke in pregnancy? So actually, there are three proposed mechanisms, but the one that I highlighted with the red, no, are those that are related to your hemorrhagic stroke. So we all know that during pregnancy there are hemodynamic changes, no, due to the increased high metabolic demand. So therefore there will be a change, no, a maternal change, no, physiologic changes, no, for to meet that demand, no, and one of those is actually um, an increase in your plasma volume. But as mentioned earlier by Dr. Wanod, you expect somehow that there should be a precipitous drop or a decrease in the blood pressure towards the latter part of the pregnancy. But however, if you are predisposed already, or if you have chronic hypertension, likely gihapon that you will still have an elevated blood pressure. Okay. Another thing that actually is a big contributory for your hemorrhagic stroke is your vascular and connective tissue remodeling. So they say that during the first trimester, there are increased vascular distensibility to accommodate for the increased plasma or increased volume, no? So that's what happens. So there's remodeling of your blood vessels to allow to accommodate for the increased volume, plasma volume. However, in the late pregnancy, there is a loss of distensibility due to the reduction in your collagen and elastin in the systemic arterial wall. So what happens is because of the loss of distensibility, given if the patient is hypertensive, no, that shear stress, given the loss of distensibility, will actually result to rupture of your blood vessels, no? So that would result to a hemorrhagic stroke. The third mechanism for stroke is the changes in coagulation system. It's more related to your ischemic stroke, no? So as mentioned earlier by Dr. Ruano, the pathology for your intracerebral hemorrhage is your lipohyalinosis. So basically, your lipohyalinosis are just accumulations of fibrillary materials due to chronic hypertension. So what happens? The fibrins, no, will actually, if you can see the slide, no, um, the fibrinoid materials will actually accumulate beneath, no, your arterial wall, no. Then this will predispose somehow to weaken your arterial wall. And given that during pregnancy, the loss of decrease in your collagen and elastin will actually even result to a decrease or makes the arterial wall more vulnerable for rupture. Another mechanism or another pathology that you see is your Charcot-Bouchard aneurysm, as mentioned earlier also by Dr. Uwano. So what happens is because the loss of your elastin, no, um, the weakened arterial wall or loss of your elastin, no, will actually result to a rupture, no, and this will actually result to intracerebral hemorrhage. This pathology would actually is usually seen in cases wherein you have your small penetrating arteries. So those small penetrating arteries are actually located on the common sites of your bleeding. No? So small penetrating arteries are small arteries that are branching off from your large vessels or large arterial vessels. No? So these small penetrating arteries, because of increased shear stress coming shear pressure, no, coming from your, if the patient is hypertensive and there's shear pressure, no, if it branches off, no, from a large artery, of course it, if the arterial wall is fine, of course it can accommodate that shear stress or pressure. But as time goes by, if that pressure is not yet controlled, and given the pathology that happens occurs due to chronic hypertension, this will resort to your rupture. So that's why it's common to see your bleed in the basal ganglia area, which is in B. This one is your basal ganglia, or your and also your thalamus. No, can also occur in your lobar bleed. No, but lobar bleeds are usually associated with AV malformations. Your pontine bleed, as in the case of your patient, no, so it's quite unusual actually to see pontine bleed, but it may occur, and in this case it actually happened to our patient. And last of all, are cerebellar bleed. As to the most severe, no, in terms of morbidity and mortality, it's your pons actually is the most has the poorest outcome when it comes to the side of bleed. That's why I'm quite surprised, no, that the patient survived, no. So lucky, very lucky good siya. And of course, the team actually took care of the patient very well, and lucky good na nakaulit good siya, or the patient got home. So what are the treatment principles in hemorrhagic stroke? Of course, we need to do strict BP control. No, as mentioned earlier, no, especially in the first 24 hours when the patient presents in the ER, the most important is strict BP control, because in the first 24 hours, particularly in the first 6 hours, no, expansion hematoma is the common, no, cause of neurologic deterioration. So that's why it is important for you to really uh, strictly control your blood pressure. As in this case, the pontine bleed, no, given that the location of the bleed is in a very small area, because remember, pons is part of your brainstem, and a lot of tracks, no, fiber tracks, no, or structures passing, no, from your brain, from your cerebrum, no, to back to your spinal cord, passes through that. That is also where your consciousness is. So if that small area, no, if the bleed will expand, chances are this patient will actually deteriorate further, and might even result to either a comatose state or mortality. So a strict BP control really is important. Now, as for the 5H principle, you need to make sure that when you're managing actually stroke in general, you need to avoid hypoxia, hypovolemia, avoid hypertension or hypotension. Make sure that there's no fever. That's why I need to address if there is any infection. And of course, manage the metabolic parameters as well. Now, um, in this case, no, I noticed that in the case they use medical decompression, which is mannitol. Well, decompression is given if it's clinically warranted or if it's warranted. In this case, though, I'm a bit I did a bit to disagree. Although when it comes to the use of mannitol in this case, no, given that you have already the benefit of your CT scan showing a bleed in your pons. The problem with your mannitol is that your mannitol addresses cytotoxic edema. So cytotoxic edema is the edema of your cells, no? However, in your pons, majority are your fibers. So there are no cells there, but just your fiber tracks, no? So mannitol is not of use, no use, no? Unless, no, that bleed or the blood or the hematoma will spill over to the fourth ventricle, no, or your aqueduct of Sylvius, which will cause your what we call an obstructive hydrocephalus. If that would be the case, then yes, a mannitol would be an indication for the case, no? But in this case, I think the mannitol was, for me, is not warranted, no? All pontine bleeds actually are not, usually with pontine bleed, we don't use mannitol unless there is obstructive hydrocephalus. Now, surgical decompression is necessary if usually if it's a lobar bleed. But in this case, as mentioned earlier by as I mentioned earlier in the course, no, neurosurgery is of no use because the pons is not, it's non-surgical for the case, no. Then of course, should we wait or should we deliver? So actually, in this update, no, in stroke in pregnancy, they say that if there is eclampsia or health syndrome, yes, you need to induce labor and delivery. So in this case, I think that it was clinically warranted. Now, another issue that I saw, no, is there such a thing as seizure prophylaxis? In this case, though, I noticed that initially when the patient didn't have a seizure yet, they started a anti-epileptic drug or anti-seizure medication. Actually, if you look at literature, no, um, in terms of intracerebral hemorrhage, there is no role for seizure prophylaxis. The only role that you can use actually for seizure prophylaxis are as follow: your subarachnoid hemorrhage, but it should be short term, and there are only in selected cases where you use it, no? And also your traumatic brain injury, which is also short term. Now, I noticed that in your patient, no, the patient had a seizure. Okay, so whether the patient had a seizure, especially in an early onset, no, or early onset seizure, meaning the seizure occurred within a week from the time the patient had a stroke, no. If it's an early onset seizure, chances are this patient will not have the chances are that the cause of the seizure is actually a metabolic cause or due to hypoxia. So it's like a secondary cause, no. So you need to figure out, no, what's causing it. It may or may not need a seizure medication, depending if you were able to address ahead of that, or if you're able to identify immediately the culprit on what caused the seizure, early onset seizure. So that's one thing, or take home message as well when you use seizure medication in patients in general for stroke.